My name is Ann Monroe. I'm a pain management physician with Holland Hospital. Welcome, and thank you for coming. I am going to be talking tonight about low back pain, and hopefully in the process giving you a better understanding of low back pain and the things that cause it, and some of the things that we can do to help treat it. All right, so first things first, what's back there anyway? I always try to include a little anatomy lesson in my discussions with patients. I think it's important to know what makes up the lumbar spine to help understand what might be hurting, why it might be hurting. It helps in communicating what's wrong with your doctor, and it helps in an understanding of the anatomy of the lower back and the pelvis also can help you be more involved in caring for your back. All right, so here we go, starting with the anatomy. Now, if I lose any of you or there's something that you don't understand about what I'm saying, please just raise your hand and ask me. We want to get the most out of our time tonight. So this is a diagram of the spine, and the spine is made up of individual bones called vertebrae, and they stack on top of one another. And it starts at the base of our skull. Let's see how good I am with this laser here. So the base of our skull, and it goes all the way down to our sacrum, which is that triangular bone in the middle of our butt. Most of us call that the tailbone. We've broken the spine down into 3 separate parts just for naming purposes. And those last 5 bones here, we've termed the lumbar portion of the spine, or what most people refer to as their low back. And that's what this model, well, that most of you can't see, represents, is the lumbar spine. So this, in the model, and I guess not everybody can see it really well, but this is the front of the spine, and you see that here. And then this is the back of the spine. This is actually the part that, if you were to run your hands along the center of your spine, you can feel. You're feeling these bones here. So this is the posterior part of the spine. L1 is the first lumbar vertebrae, L for lumbar, and then L2, 3, 4, and L5. So L5 is that last bone. And then we term this disc here the L5-S1 disc, S for sacrum. All right. And these are some slides just showing, again, some basic structures of the low back and how they come together to form the spinal column. And I'll get into these structures one by one, but here we have the vertebrae. So remember I was telling you those separate bones. But we're looking at it now from a top-down view. And you can see here really nicely that spinal canal. And then this is just a representation of how they stack on top of one another. So here we've got what we would call a lateral view of the spine. And then this one shows you some of the soft tissue structures. So the discs that's sitting between the vertebrae and the nerves as they're coming out of the spine. And I'll go into all that in more detail. All right, so the first structure we'll talk about is the disc. Most of us have heard of it, discs or disc bulging or disc herniation. So the disc on the model and in this sits in the front of the spine, so it's an anterior structure. And you can see it right there between the body of the vertebrae. The body is the largest part of the vertebrae of that bone. The disc is made up of 2 components. It's got an outer layer that we call the annulus. These elastic fibers that come together to form a very tense and yet elastic structure. And then in the middle, you've got the nucleus, which is a soft gel-like substance. These 2 structures, or these 2 components that make up the disc, allow for motion and flexibility of the spine. They absorb and distribute loads that are applied through the spinal column. And it's responsible for about 25% of the spinal column height. All right, and then we have the nerves. So as these vertebrae, as these bones stack on top of one another, they create a bony canal through which the spinal cord runs, and we call that the spinal canal. So you can see that here on the model. At each vertebral level, the nerves are exiting as they come off of the spinal cord and exit through the neural foramen. The neural foramen is the name we give for that hole right there that you see the nerve coming out of, and that's represented right there in this slide. As the nerves exit the foramen, they're coming out to come into the leg to provide motor function to the muscles in the leg, and then sensation to different parts of the skin in the leg. And now the facet joints. So the facet joints are a posterior structure, so they're in the back of the spine, just off of center on the left and the right. The only place where the two vertebral bones that are sitting on top of one another meet is in the back of the spine. And where they meet, they create a true joint that we call the facet joint. And then more superficially, the vertebrae are held together by muscles, their tendons, and then ligaments. There are many structures in the pelvis, and that can contribute to pain and functional limitations, but that would be a whole other lecture. But I did want to briefly mention the sacroiliac joint because I see a lot of patients with pain in this joint, either all on its own or as a part or a combination of with low back pain issues. And a lot of people will confuse sacroiliac joint pain with low back pain. So that is right here on the model. Okay, so that would be where your sacrum, so this triangular bone here, remember we said that sits in the middle of the butt, meets up with the pelvic or the hip bones. And where those two bones meet on the left and the right, they create or they form that sacroiliac joint. Now that joint, if you put your hands on your hips and kind of follow down, you'll get to a bony prominence. A lot of us will have a little dimple there. And that's the start of the sacroiliac joint. And then if you follow down a couple inches, you're running your finger along that joint line. All right, so causes of pain. The most common cause of pain or of back pain is injury to a muscle, which we would term a strain, or to a ligament, which we would term a sprain. And this can occur for many reasons, including proper or improper lifting techniques, repetitive lifting or repetitive twisting. And I'll see these kinds of injuries very often in factory workers because they have that same repetitive movement over and over for hours at a time. Excessive body weight and poor posture are other things that can put a lot of strain on the muscles, causing injury. Sometimes a strain or a sprain causes immediate back pain, and then other times the soreness and the stiffness can come later after the injury occurs. Symptoms of muscle injury are usually limited in duration. Usually the pain is going to be more intense in the initial few hours and days. There can be increased pain with certain movements or positions, and usually when doing something that causes jarring or contraction of that injured muscle. Ongoing moderate pain and stiffness can be experienced for 1 to 2 weeks while the muscle heals. And an injured muscle or ligament is usually pretty straightforward to diagnose. It's, as muscular pain is usually reproducible or touchable. So you can run your hand along the muscle that's injured or hurting or spasming, and you can feel the pain. Of course, there can be exceptions, and sometimes more severe injuries, like a complete muscle tear, can take longer to heal, up to months. And then sometimes muscle spasm is just one part of a bigger problem within the low back. And the spasm is not the main cause of the pain, but actually a symptom of it. So for instance, I've seen patients who'll have a disc herniation and it's pressing up on a nerve, and you'll see the muscles in the back start to contract almost to try to help open up that space that the nerve is running through where it's being compressed. So in that instance, the muscle's contributing to the pain, but that isn't the primary problem. All right, and then going deeper, so disc pain. Disc pain is often the result of disc degeneration. Degenerative disc disease is what we give that term, and it's fairly common. It's estimated that probably at least 30% of people between the ages of 30 and 50 years will have some degree of disc degeneration. And then by the time we reach 60, some level of disc degeneration is normal, a normal finding on an MRI rather than the exception. Lumbar degenerative disc disease, in simple terms, is the wear and tear of the intervertebral discs. that act as a cushion for the spine. So this structure here that we pointed out. This wear and tear is usually the result of normal aging, but it can also have a traumatic origin that can then progress over time. With increasing age, there are changes at the molecular level or in the molecular composition of the disc that, among other things, will lead to decrease in water content of the nucleus, which is that central portion of the disc, and it can lead to tears in that outer portion, that annulus, fibrosis. And this loss of hydration leaves the disc more susceptible to damage. Disc degeneration can lead to disc bulging or herniation. It can lead to loss of disc height, so shrinking of that disc, and even changes in alignment over the course of time. And a lot of people talk about shrinking or getting shorter as they age, and this is a big factor. It's that decrease in height of those discs as they degenerate and as they lose water content. And then this diagram goes through some of the progression of those changes in the disc. So again, we have a top-down view of the spine here. We're looking at that inner nucleus and then that outer annulus, that outer ring, so those two components of the disc. And this is what it looks like when it's normal and healthy. And then over time, you can start getting changes in that nucleus, drying out. You can start seeing tearing in that annulus, in those fibers that make up the annulus, as that progresses, because it is a gradually progressive process. We term this arthritis of the spine. It's not technically an arthritis, but just like arthritis, it's age-related. Once it starts, it gradually progresses. And as it progresses, those tears can get worse. There can be further weakening of those disc structures, and you can start getting bulging, disc bulging. And then it can advance to the point where you get a tear in the annulus through which that nucleus material will herniate. So when we talk about disc bulging, this is what's happening. When we talk about disc herniations, that's what's happening. And then this is an MRI. I just think MRI images are cool. I hope you do too. But this is a lateral view of the spine. So we're kind of, the MRI takes like slices, kind of like slices of bread, and you get to see in between those slices. And so here's the body of the vertebrae of the bone, and then in between the bones is the disc. Now up here, you have a nice healthy disc. That white that you see, that's water. So there's lots of water. Those are nice hydrated discs. You can see how nice and thick it is. And you can compare it nicely to those lower levels. So here we're starting to lose height. You can also see that there's not that much white material there, so this disc is losing water content. It's degenerating. And then here you can see even further the consequences of that degeneration as that disc starts to bulge or herniate. So it's pushing past that margin that it's supposed to be contained within into the spinal canal. That's what this is. I think we now believe or know that genetic factors are the most important predictor of disc degeneration. External factors like occupation and heavy lifting are more minor contributions. So your genes really do depend or determine how early on you're going to start to develop this degeneration and how easily those discs may be injured or accumulate that wear and tear. So symptoms of disc pain or degenerative disc disease, low back pain that many will describe as a deep ache or a pressure type pain. The pain usually is going to be centered in the middle of the back, but can radiate out from there. So people will describe feeling pain that moves out to the left or right. Sometimes they'll describe it as a band-like pain along the back. Pain from disc degeneration or disc injury can worsen when we bend, lift, twist, cough, sneeze, and even sitting with certain postures. These are all things that put movement or pressure through the disc. So that makes sense why those things would aggravate that pain. And then generally disc pain is going to be relieved when lying down, so when you're taking that pressure off of the disc. All right, and then the joints. So we said that the facet joint in the back of the spine, that structure posterior there, is a true joint. And what that means essentially is that just like any other joint in the body, you can get arthritis in it. These changes may happen independently, determined by genetics. So some people, as part of their degenerative changes in the spine, will have a predominance of arthritis in those facet joints. And then sometimes it can happen in association with disc degeneration. So without the cushioning that the disc normally provides and the height between the two bones, as that disc degenerates and narrows, the joints are going to press more tightly against one another, and that can leave the joint more susceptible to developing arthritic changes.
Excuse me?
Yes.
So there's not much you can do about the degeneration? I mean, it's just because you get older it happens that you can't do something to...
You can't, it's like arthritis of the hip or the knee. Once it sets in, it's there to stay, and it gradually progresses. We'll talk a little bit about what you may do to help yourself, but in terms of stopping or halting the process, no, you can't. And then this is a diagram going through, well, just looking at the facet joints here and kind of how they bear movement with certain, with flexion or extension, bending of the spine. And then this one here shows what we call facet joint hypertrophy. So as part of the arthritic process in those joints, the bones that make up the joint can enlarge or get bigger. And so we term that process hypertrophy. And that's how this arthritic process within those joints can start to take up more space, affecting the structures that are near them. Pain from facet joint arthritis is not specific. Generally, it's described as an aching pain experienced a little off a center, bending back or extension of the spine, particularly with rotation at the same time, does cause compression of the facet joint and can be more uncomfortable in patients with pain stemming from these joints. And people will often talk a lot about pain that's worse when they get up in the morning. That eases up as they move through the day and then can get a little worse towards the end of a long day, which is a pretty typical way of people to describe the onset of arthritis in any joint. All right, and then nerve pain. So remember that we said at each level between the two vertebrae on the side here, there are nerves coming off the spinal cord. As these nerves leave the spinal canal, they exit through a bony canal or an opening on the side of the spine. And that happens on both sides at each level as they're on their way to feed sensation and motor function to the legs. We call this canal on the side here, the neural foramen, and I mentioned that before. Neural means nerve, foramen means hole, so it's the hole that the nerve comes out of. Within the spinal canal, so through this central space here, or through that neural foramen, the nerve can be pinched by anything that may be narrowing those bony canals, anything that's taking up space there that's not supposed to be. And we call nerve root compression radiculopathy. That's the technical term for it. And then this is just a diagram for those who can't see the model, just showing you the nerves running, that spinal cord running through that central canal, and then the nerve roots exiting through that little canal on the side. All right, so a nerve can be pinched by a herniated disc. So we said when they herniate, they often, almost always, bulge backwards into that spinal canal where the nerves live. Bony spurs can also form off of what we call the end plate, that edge of that body of the vertebrae. And if they extend posteriorly into the spinal canal, they're going to take up space where nerves live. And then the bony overgrowth of the facet joints, so the hypertrophy that we were talking about, is another way. If that enlarges, that's going to start narrowing that space there, and it will also narrow that central canal. And then this diagram goes through, I hope it makes sense. It was the best one I thought I could find. So again, we've got a top-down view of the spine. Right here you're seeing the little nerve roots. Not all of them exit at the same level, so you're seeing some of them are still making their way through. That's what this is. And then at this level you see that specific nerve root coming off of the spine and exiting through the foramen, this part here. This is the disc, so you're looking at it sitting here. And then this is the spinal canal that the spinal cord is running through. And then this is a ligament that runs back there. And then these are the joints. So top-down view of that. So I hope that makes sense. And then this diagram is showing you what can go wrong or what can change. So the facet joint you see here is enlarging. That enlargement, that hypertrophy, is going to narrow space, the spinal canal, and it's also going to narrow that foramen, that neural foramen that the nerve is exiting through. This ligament here can start to thicken. You can get a hypertrophy of that as well, which is another way that you can start narrowing that central canal. And then the disc can start to bulge. And now this doesn't show, I guess they're trying to show it, but they didn't do a very good job. But the disc will start to bulge and it will push outward and back into that spinal canal. And the disc can bulge in different directions. Sometimes it can be a central disc protrusion or a central disc herniation, so it can take up that central canal space. Sometimes it can have more of a left or a rightward lean to it, in which case it can take up more space through that foramen. And I heard some people talking about spinal stenosis. Heard that term. Stenosis is the narrowing of an opening or a canal. So spinal stenosis would refer to narrowing of the central canal, and then neuroforaminal stenosis would mean narrowing of that side opening where the nerve is exiting. All right, and then pain from a pinched nerve is generally described as a sharp shooting pain. People will describe numb, tingling type feeling, burning, electrical type sensations. Pain often radiates into the leg, and the area that it will radiate into will be determined by which nerve is being affected. Weakness may also accompany the pain and the abnormal sensation, depending on how badly the nerve is being compressed. All right, and then sacroiliitis. So we talked about the sacroiliac joint and how to identify where it is. You can get inflammation of that sacroiliac joint. Pain caused by sacroiliitis can be related to either too much or not enough motion of the sacroiliac joint, and it can be contributed to by lack of support of the joint, like with ligament laxity, which will happen in the pregnant pelvis as the ligaments get loosened so that the pelvis can start to grow or spread and accommodate that growing baby. It can happen when you have weakness of the supporting muscles of that joint, and it can be also due to abnormal movement mechanics. This pain, though, we said was touchable, so you can find that joint and you can press on it. And a lot of times if you have active inflammation within the joint, you'll be able to feel pain. You'll be able to feel that's where the pain's coming from as you're running your hand along that joint. And this pain can be very sharp at times and aggravated really by just about every movement. There's very little that we do that doesn't put movement of some sort through our pelvis. So pain is very often multifactorial, which means more than one thing is causing it. The longer you have pain, the more time there is for other parts of the body to start developing problems that can add to the overall pain experienced, usually because of abnormal movement patterns that are adopted to avoid pain in the first place. So you get into a vicious cycle. I like to think about pain, and I talk to my patients about pain as kind of a pie. And there's more than one thing that's contributing a piece to that pie. And they all come together to create the entirety of your pain experience. And they all can feed into each other too. So we said you can have a disc herniation that's causing low back pain, and you start walking funny because you're trying to get away from the pain. So maybe you're hunched over, you're leaning over to one side because that's more comfortable. And over time, doing that though, that pain avoidant behavior, causing you to walk and move with abnormal posture and movement mechanics, will put stress through other areas of the body. And you can start to get, for instance, a sacroiliitis or inflammation of the sacroiliac joint. So now you got a new piece to that pie. And that will further cause you to walk in an abnormal way, to move in an abnormal way. Now you're going to start decreasing your activity because it hurts to move. Muscles get weak, deconditioned, inflexible, stiff Now they're starting to cause pain. So again, I was talking about that cycle. It all just starts to feed into one another. And one of our main goals is trying to get it before too many other new pieces of that pie start to add up. All right, so point is, pain is complicated. And a detailed history and a very thorough physical exam are necessary for identifying all of the contributing factors and to develop a tailored treatment plan that's specific to the individual and their pain. Oh, I forgot to put a slide in. I'll just read it. For simple back pain issues that don't require a physician, usually the general recommendation is try rest for about 24 to 48 hours, icing the painful area, and then using over-the-counter medications like ibuprofen, an anti-inflammatory. And then after those first 2 days, if possible, try to get back to as normal of a regular schedule as you can. For pain that doesn't improve over or over a few days or weeks, physical therapy is often the first line treatment. So if it's something that's lasted long enough or severe enough that you need to come to see a doctor about it, physical therapy is going to be one of the first things I'm going to recommend. It's one of the few conservative treatments that can change things for the better and change them for the long term, assuming patient compliance with therapy training and the exercise program. So when you talk about medications and injections, and those things can help too, but they're a short-lived benefit. And they're important, especially if we consider that there's not a lot that we can do to take the pain away completely. So they do have their place for a lot of people. But therapy is one of the few things that can give you, an education and something that you can take with you and apply to your everyday life. So it can give you long-term benefit. And healing can be enhanced through physical therapy, which will focus in part on the structures that support the spine. So physical therapy, some more on that. So primary goal is to return the patient to the highest level of independent functioning possible. We do that by trying to restore flexibility, mobility, alignment, in part by restoring full range of motion to the injured segments and then the adjacent segments, and implement therapeutic exercises, and then develop a home exercise program, which is the part that you're going to take with you when you're done with therapy and keep up forever on. And then I wanted to just mention the core briefly. Most of us have heard of the core, but what is that? The core is muscles that are in the midsection that work as stabilizers for the whole body. And they're going to be a focus. They're not everything, but they're a main focus of therapy for the low back and for low back issues. All right. Through therapy, lots that therapy does. You'll also be taught proper posture and techniques for bending and lifting and twisting in efforts to avoid unnecessary strain through the low back, and learning posture with sitting and standing and sleeping. So a lot of things that we just kind of take for granted, but there actually are ways that we can perform those activities that can be more responsible to our low back. All activities and positions or postures that can put a significant amount of movement and stress or load through the spine, and more importantly, that can cause a lot of unnecessary strain through the low back when they're not performed correctly. And I said before that the majority of these changes are genetic. So there isn't a lot that we can do about that part. And so to me, it's then even more important to maximize the part of us that we do have control over. And another important take-home point that I want to make is moving correctly, having good posture, having a strong core, having good flexibility. It takes a lot of work and a lot of thought, and it doesn't always translate to pain relief. But don't use that as a judge of its importance. So it's still very important, even if you still have pain when you're done with a physical therapy course, to keep up the routine that they taught you. I like to tell people that being more responsible to your low back, being stronger, being more flexible, May not translate to a lot of pain relief. We always hope that it will, and for some it can. But even if it doesn't, being stronger, being more flexible, being more aware, being more responsible to your low back is better than the alternative, right, which is having weak and inflexible muscles. And then I included, which I had hoped would have some handouts for you, but they didn't make it here. I just included some slides going over correct sitting posture, correct standing posture, and even how to sleep appropriately so that you're supporting your low back. So people they like the sleeping one, so I'll go over that one. If you sleep on your back, have a pillow underneath your head that doesn't extend the neck or flex the neck too much or allow too much extension. So it's all about really keeping the spine straight and supported. I don't know a lot of people that put a pillow behind their back, but I guess if it's more comfortable, you can do that. Usually just putting the pillow underneath your knees will flatten out the low back, and that's usually good enough. If you're a side sleeper, again, I don't know anybody that puts a pillow under their side, but definitely a pillow between the legs to keep the spine straight, the pelvis straight, and then I even recommend sometimes a pillow under the arm just to keep so you don't have that twist in the trunk. And then sleeping on the belly, you should have a pillow under your stomach if you do that. And then I included this because I just thought I don't think it's very intuitive that you can actually put more stress and pressure through your low back with certain sitting postures than when you're standing upright. So standing upright, we've got about 100% here of disc pressure. Sitting at about 110 degrees angle increases that slightly. And then as we move on here, so increasingly forward, you see we start to put more and more pressure through the discs so that at the end here, sitting forward flexed, you're almost doubling the pressure that you're putting through the discs as you were when you were standing up. All right, and then outside of physical therapy, we'll use medications to help for the pain. The first line treatment is going to be the simpler over-the-counter medications, Tylenol, ibuprofen, the anti-inflammatories. When those aren't effective, we can also move on to prescription medications, and there's medications for general pain relief. There's medications to reduce muscle spasm, and then medications that can target more specifically nerve pain from nerve compression. Yeah.
What really are opioids?
Opioids. Opiates or opioids are general pain relievers that work at the level of the pain receptor, and then they're not specific, so they can help decrease pain regardless of where it's coming from or what structure is causing it. And that's a can of worms. So they can help for pain, and for some are necessary, but they do have side effects, and sometimes very significant side effects. So you try to avoid them if you can. All right, and then there are injections available for pain. Almost every injection that we have for pain is going to be a steroid injection of some sort. The only exception to that is the knee joint, where we do have a synthetic synovial fluid that can be injected. But for everything else, shoulder, the hip, the back, it's steroid. There are, there's steroid injections that are available to target pain caused by those herniated discs that we had talked about. The steroid injections, those same injections, and those are the epidural injections. Not only can they help disc pain, they can also help decrease or relieve nerve pain. And then there are injections that can more specifically target the facet joints, so helping for the facet joint arthritis pain. And then sacroiliac joint injections as well. Injections are relatively safe, and they can provide a way to reduce or remove pain without taking medications. It's an outpatient procedure. Usually takes only about 10 to 15 minutes to complete. So fairly easy. I guess that's easy for me to say, I guess. Over the long term, surgery and non-surgical treatments work about the same to reduce pain and other symptoms if you're looking at patients several years out. When all else fails, though, surgery can be an option for some, and usually is necessarily for a small number of patients. Usually about 10% of people who have herniated discs need to progress to surgery to help it. Surgery may be considered more seriously for people who have progressive nerve damage, so who have severe weakness or sensory loss as a result of that nerve damage or nerve compression. And then for those whose pain hasn't been relieved very well by other more conservative measures. You didn't get all the ones. Okay. I also included a slide that you can't see. What can you do for yourself? You can eat a healthy diet. So a strong body needs the right kind of nutrition to stay that way. Avoid excessive weight. The more you weigh, the more pressure and stress you move or you put through your body and through your low back. And excessive weight can also change the way that we move, our patterns of movement, in ways that are not good for our body or for our low back. Exercise regularly. And do it with a routine that includes stretching and strengthening. And if possible, choose activities that involve less impact on the body, like bicycle riding or swimming, or an elliptical versus a treadmill. And then be mindful of your back with the way that you move and maintain good posture. And but you should see in all of that, a lot of that I'm talking about there are things or principles that you'll learn with physical therapy. But those are all things that you can do to help yourself. All right, and then that's the end. So thank you for being here. Any questions?